I'm going
There's a sharing button at the,
yes.
Yeah.
Can you see my slide now?
We've got it.
Very good. So I'm going to discuss the role of finerenone in the therapeutic armamentarium. In fact, I'm actually very delighted to have Peter Kolkoff on the panel because Peter, as you know, has discovered this molecule. And I had the opportunity to visit Peter Kolkoff in his laboratory in Wuppertal. And it took almost a decade to discover and optimize the molecule. And 20 years later, we actually have an amazing product. And really, I'm humbled by literally thousands of people whose efforts go into discovering something so important for the care of our patients. To give you a little bit of background, in nephrology, we have always had gloom and doom. In fact, when I was at All India Institute, there wasn't any therapy for people with diabetes and kidney disease. What did we do? Protein restriction and low sodium diet and some pills to bind phosphorus. And most people were anemic and they went on dialysis and we just watched helplessly. And in 2001, we discovered that the ACE inhibitors, ARBs, work very well. And after that, we had nearly 20 years of no therapy. Not that we weren't trying, we were trying hard, but we never discovered anything of substance. In 2019, we discovered that SGLT2 inhibitors really work well, and that was a breakthrough discovery. And the effect size of the SGLT2 inhibitor was quite remarkable, about 30%. And then we discovered finerenone 2 years later. In fact, in 2020, these findings were published. So literally about 18 months later, after the first discovery of a publication of SGLT2 inhibitor, finerenone was published. So it didn't really take that much time for us to discover two amazing, wonderful drugs. So now we have a tripod of therapy, ACE inhibitors and angiotensin receptor blockers forming the base. Then we have SGLT2 inhibitors and finally finerenone. And you might think, okay, which one comes next? And we will address this question. But before we go into there, I will walk you through the process. These are my disclosures. To be sure, I have consulted for both the makers of finerenone and SGLT2 inhibitors. Now, in nephrology, we have developed a strategy much like oncologists. We stage kidney disease. You have heard of T&M classification of tumors, and we really have a bivariate classification in nephrology, and it's predicated on two simple facts. One, that if your kidney function declines, you have an elevation of risk of cardiovascular death and cardiovascular events and kidney failure and even acute kidney injury. That's the first belief. The second belief is that if the albuminuria increases, we have a similar increase in risk. And this is shown here on this slide. And remember that 30 milligram per gram is the threshold where we call it microalbuminuria. So 30 to 300 is microalbuminuria. And if we go to macroalbuminuria, the risk of cardiovascular death is already more than threefold elevated, threefold, not 30%, threefold, 300%. And the risk actually starts rising somewhere around 10. When you have microalbuminuria onset, your risk is already doubled. So we might think, oh, there's nothing to worry about, a little bit of protein in the urine. But a little bit of protein in the urine is a big deal. You actually have an increase in risk. And we know this from epidemiological studies. For example, here's the advanced study. It was done in people with diabetes. And it shows that as the GFR declines and as proteinuria rises, so does the risk of kidney failure events and cardiovascular events. Left side, kidney events, right side, cardiovascular events. And you can see people less than 60 and a lot of albuminuria, the risk is elevated. And people with low kidney function and increase in albuminuria more than 300. Hazard ratio is nearly 6. These are the people that nephrologists typically see, not so much the internist or endocrinologist. But notice that even if the albuminuria is a little bit elevated, 30 to 300, you can see even if the GFR is more than 90, the risk of cardiovascular event is twofold. And similarly, the risk is elevated with kidney failure. Kidney failure events requires more proteinuria, but you can already see the risk of cardiovascular deaths increases. So what do we do with this information? Well, we take this information and create a grid. And on this column, you see GFRs going from more than 90 to 15 to 29. And on the rows, you see the CKD prognosis by eGFR and UACR going from normal albuminuria to macroalbuminuria. And using this grid, you can say, you can classify the risk. For example, people who have no albuminuria and have GFR more than 60, they're at low risk. These are people who are generally healthy, even though they might have diabetes, their risk is not that high. But if you have slight impairment of GFR, which means stage 3A CKD, 40 to 60 GFR, or microalbuminuria, regardless of the GFR, your risk is moderate. And then you get a high risk if you go 3B GFR, or if you have a 3A with microalbuminuria or any macroalbuminuria. And if you combine macroalbuminuria with a stage 3 or more CKD, you're really at high risk. And that's a recognition that sometimes we don't make, even though we might know about it, but we don't connect the dots and say, oh, this patient is really at high risk. So finerenone trials were a program, and they were named after two operas, Fidelio and Figaro. These are two operas. Fidelio was a trial that was done in people with type 2 diabetes and chronic kidney disease. They randomized 5,734 patients to either finerenone or placebo and followed them for a median of 3 years, 2.6 years actually. And in these people, the primary outcome was a kidney failure outcome. So we are counting the number of people who go on dialysis or have death because of kidney failure or have a sustained decline of GFR of 40% or more. Okay, that's your Fidelio trial. But in that trial, we are looking at people who have a GFR between 25 and 75. And most of these people, 90% of them, have macroalbuminuria. Only 10% of people have microalbuminuria, and microalbuminuria meaning 30 to 300. And in these people, we require diabetic retinopathy to get in the trial. The FIGARO trial expanded this, and we said that anyone more than 90 eGFR can get in, and you can have even microalbuminuria and you can get in. And the primary outcome in the FIGARO trial was cardiovascular, a 4-point MACE, which means cardiovascular death, myocardial infarction, stroke, or hospitalization due to heart failure. And we have 7,437 patients randomized in the FIGARO trial, again, to finerenone and placebo. And the primary endpoint of Fidelio was cardiovascular. Fidelio was renal. Secondary was cardiovascular. In FIGARO, it's flipped. In FIGARO, the primary endpoint is CV, and the secondary endpoint is kidney. So we basically have a very rich database now of very similarly designed trials in a broad population of patients. So instead of slicing and dicing the data, I thought I would present you the big picture view of all the 13,026 patients that we randomized between the two trials. So let's go through the trial a little bit. You have basically 2 time points during which you have the patients come in, separated by 4 to 12 weeks. And in these 2 time points, we draw a blood lab for serum potassium. Potassium has to be 4.8 or less to get into the trial. And the reason we did this is because we knew that we are using an MRA. And if we use an MRA, the potassium can get elevated. And we didn't want patients to start taking the drug and come off the drug 2 weeks later. So he said that if you include people who are close to 5.5 and you start the drug and 3 days later you got to stop it, you're not going to get benefit. So you have to take some room where potassium can go up, which is fine, but the patients continue the drug. So we make sure that you have some headroom where potassium can go up. Besides that, everybody had to have chronic kidney disease and type 2 diabetes, and we excluded patients with symptomatic heart failure with reduced ejection fraction. Why did we do this? Because in these people, spironolactone is indicated, and you can't deny a class 1A treatment, even though these people are participating in a randomized trial. Also, during the 3 to 4 months that these patients were being seen in the run-in period, we optimized the dose of ACE inhibitors and angiotensin receptor blockers. And by doing that, we were basically making sure that the people who get into the trial are truly ones whose albuminuria is elevated despite maximally tolerated standard of care. So we now have people going from anywhere between 25 and 90 GFR, right? And we have only excluded those people who have no albuminuria. And this is not unique to this trial. We actually have no trials in nephrology which include people without albuminuria, because these people, although they are very important, they don't have as many cardiovascular events and kidney failure events. And these are trials that go on for many years. We simply don't have the resources right now to include these people in the trials because they don't progress that much. Now, in the fidelity analysis, as we call it, we call this analysis, we pre-specified that we will have a cardiovascular outcome, which is a 4-component MACE, which I've already told you about. And we will have a kidney composite outcome, which includes people going on dialysis or have a GFR less than 15, those people who die because of kidney failure and never go on dialysis, or people who have doubling of serum creatinine. Now, doubling of serum creatinine is a 57% decline in eGFR. You do the math and you say, okay, if you doubled your serum creatinine, you actually have a 57% decline in eGFR. Now, that's not the endpoint we used in either FIDELIO or FIGARO as a primary endpoint, but we had pre-specified as a important secondary endpoint in both these trials. And for the fidelity analysis, we had pre-specified that we will use 57% decline because it makes us comparable with the other trials. For example, IDNT, Renal, Credence, etc. They all use doubling of serum creatinine. Now, here's the trial population. And you might say, okay, there's nothing here. Well, there's actually a lot here, which would impress you. First of all, these people are older, 65 years of age, and they have diabetes, about 15 years with reasonably well-controlled diabetes. The average hemoglobin A1C is 7.7. Blood pressure is reasonably controlled, 137/76. Half of them have cardiovascular disease. Everybody is on ACE or ARB, 72% of the people on SGLT2 inhibitors. And at baseline, 7% of the people approximately are on SGLT2 inhibitors or a GLP-1RA. Now, if you look at these trial data and ask the question, you're going to put another drug and you think that you're going to show an improvement in cardiovascular outcome and kidney failure outcome, that's a very risky proposition. And it was. When we were doing the trial, there were actually 2 trials that were published. They were called Altitude and VNephron-D that were trying a combination of RAS blockade. And both of them were terminated early because of dangers of hyperkalemia and dangers of AKI. And everybody was laughing at Bayer because they said, why are they investing so much money? They're throwing away the money because we already know this is not going to work. So they really took a risk in investing in 13,000 plus patients to take this trial to completion. And that's not a small deal, because I have participated in trials in which they have stopped the trial because they felt that they are not going to meet the endpoint. But here's a trial that they just sat tight and continued it to completion. While the mean GFR is relatively well preserved, 57.6, but notice that 40% of the people in this trial have a GFR more than 60. These are people who won't be even called as chronic kidney disease, because by definition, we actually are hunting for people GFR less than 60 for 3 months or more to define chronic kidney disease. But if we did that, we don't even identify these patients. So how did we identify these 60% of the patient, 40% of the patients? It was because we dipped the urine. We looked at USCR, and that was elevated. And you can see the distribution of the kidney failure stages on this slide. And you can see the majority of the people are on very high risk or moderate risk. Low risk is about 64 patients, almost nothing. And stage 1 kidney disease with microalbuminuria, we have about 200 patients. So not too many there, but all the other stages are well represented when they have albuminuria. So these findings are generalizable to people with albuminuria and chronic kidney disease. Here's the primary outcome in the fidelity analysis. Now, remember, these are data from over 13,000 patients. And you can see the curve starts separating about 6 months, and they continue to separate. And there's a 14% relative risk reduction in the cardiovascular event rate. The p-value is highly significant. And what it means is that if you treated 46 patients for 3 years, you can expect to save 1 outcome. What was driving this endpoint? It was really hospitalization due to heart failure and somewhat cardiovascular death. You can see that people who took finerenone, you can tell them, you have a 22% less risk of coming to the hospital with shortness of breath, which is hospitalization for heart failure. And that is an important outcome for the patient because it makes him feel better, stay out of the hospital, not come in with shortness of breath. And that's a very important patient-centered endpoint. Notice that the effects of this drug were independent of albuminuria or urine albumin to creatinine ratio or GFR. Everybody benefited. But I often get asked the question about, did people on SGLT2 inhibitors benefit? And notice that there are people, about 900 people who are on SGLT2 inhibitors. And even if you are on an SGLT2 inhibitors and you got on finerenone, you have a 37% less risk of progressing to having a cardiovascular event. You have a 13% risk reduction when you're not an SGLT2, but with an SGLT2, you have a 37% risk reduction. You might be tempted to think, oh, it should always be used with an SGLT2 inhibitors. And while these are subgroup analyses that don't prove cause and effect, yes, it would be important to have all the 3 drugs in the patients on board, but it is important to know that these drugs work independently of SGLT2 inhibitors. For example, you might have a patient who has recurrent UTI or genital mycotic infections, or potassium is very, very low, 3.4 or something. You might consider using finerenone in that patient because that patient might actually benefit by increasing potassium and not be exposed to risk of further genital mycotic infections. On the other hand, if you have hyperkalemia or you have poor diabetes control, you might want to consider SGLT2 inhibitor as a first-line agent and then add finerenone. Important to get all the 3 drugs on board, but don't be tempted to think that this should only be used in patients who are already on SGLT2 inhibitor. It works as good in people with or without SGLT2 inhibitor. Moving on to kidney failure endpoint. Now, kidney failure endpoint, as I told you, was a doubling of serum creatinine, going on dialysis, or dying because of kidney failure. And here you can see the curve start separating at about 1 year, and they stay separated. The p-value is highly significant. You have a 23% relative risk reduction, and that is on top of ACE and ARB. And that's a big deal because in the prior trials like Altitude trial and VNFRON trial, we actually tried the combination of ACE and ARB therapies. They never worked. They never actually showed a benefit. So this is like combination RAS blockade, and it's working. So how you're blocking the renin-angiotensin system matters. And this slide shows you that there's a nice separation. What was driving the endpoint? Everything, whether you talk about doubling of serum creatinine or having an eGFR less than 15 or having kidney failure except renal death, hardly anybody had it. There were only 6 patients. But notice the most dreaded complication of person with type 2 diabetes and chronic kidney disease is dialysis. They always say, Doc, am I going to be on dialysis? And if they are on dialysis, their life changes. They are miserable on dialysis. And this drug is reducing the risk of going on dialysis by 20%. The hazard ratio is 0.8, and that's statistically significant. So now what do we have? Basically a drug with people with type 2 diabetes and chronic kidney disease, where if you use this drug, you have a 22% reduction in having heart failure hospitalization and 20% reduction in going on dialysis, which are both very meaningful endpoint to the patients. What about side effects? Well, there's a small drop in blood pressure, about 3.7 millimeters at 4 months. There are no sexual side effects because this is a very, very selective blocker. It doesn't block the androgen or estrogen receptor. It's selective to the mineralocorticoid receptor, and therefore you don't have any sexual side effects. And people have hyperkalemia. That's really the only side effect that we need to be concerned about and monitor these patients. So after you start the drug, have the patient come back in a month to check the potassium, and then thereafter every 4 months. That's what we did in the trial. If you do this, you find that the people who experience potassium of more than 5.5 double. It goes from 6.9% to 14%. Stated another way, 86% of the people who get finerenone will never experience hyperkalemia. 14% will. But you want to identify those 14% by checking the labs 1 month after you have started the drug. How many people will have permanent discontinuations? About 1.7% compared to 0.6% in placebo group, which means that you will have to write about 100 prescriptions before you will stop one person's finerenone because of hyperkalemia that is not manageable. Now, what about albuminuria and CKD? Well, it turns out, even if you look in the United States, you have very poor recognition of kidney disease. If you have CKD 1 or 2, about 95% of the people are not even identified as having kidney disease. If you have stage 3, 82% don't have recognition. Even stage 4, 47% don't have the recognition that they have kidney disease. And stage 5, similarly. So people might be recognizing that they have an elevated creatinine, but CKD as a diagnosis is often missed. And the use of ACE inhibitors and angiotensin receptor blockers, which is a guideline recommended therapy, is similarly poor across the countries. In the United States, about half the patients are on these drugs when indicated. In Netherlands, 57%, in France, only 29%, and UK, it's 2 out of 3. So in UK, where you're doing a national diabetes audit, you only have 2 out of 3 people on these drugs. So 1 out of 3 still not on these guideline mandated therapies. What about albuminuria? Well, it turns out that if you look at the distribution of albuminuria, you have this is the baseline eGFR. 2 out of 5 patients in this trial had 40%, or 2 out of 5 patients had a GFR of more than 60. And that's important to remember. and 2/3 of the people have macroalbuminuria. 1/3 of the people have microalbuminuria. So if we really have to identify these patients, we actually look at not just the GFR, which is often what we do. We have to start looking at the urine. Urine albumin to creatinine ratio is an important test to get done, especially in type 2 diabetes. And the guidelines tell us that any patient who is diagnosed freshly with type 2 diabetes ought to have this test and then annually thereafter. You don't need to collect a 24-hour urine. You can have the patient pass urine in a cup and give it to the lab. And if you measure the ratio, that's all you need. It's even slower than a blood draw. It's not even a needle stick. It's just passing urine into a cup. So to summarize, the assessment of cardiovascular and kidney failure risk is bivariate. I told you like a T and M classification, you have a GFR albuminuria classification. The recognition of CKD, especially based on USCR, is poor. Finerenone, as we discussed, is a selective non-steroidal MRA that effectively reduces cardiovascular and kidney failure outcomes in patients with type 2 diabetes across a broad continuum of patients with CKD. And patients with CKD and type 2 diabetes, if identified early, especially by USCR screening, can now have effective reduction in cardiovascular risk. People who are listening to this talk, probably 1 out of 3 have diabetes. And if you have type 2 diabetes, do you know your USCR? And if you don't, it's very simple to get it measured. I looked up the cost of it in India. It's less than 500 rupees. So I think it's a worthwhile test getting done for yourself if you have type 2 diabetes and for your patients. Thank you very much for your attention.